أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم نحمده ونصلي على رسوله الكريم أما بعد أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Hello my dear students, how are you? Hope you will be fine and in good state of health. I always start my presentation with this prayer. Allahumma arfa' anna al-bala'a wal-waba'a. ए मेरे प्यारे अल्लाह, हमसे मुसीबत और वबाई बीमारियों को हटा दीजिए. आमीन सुम्मा आमीन. Last time we discussed various conditions of intestine, then culminating with intestinal obstruction. Then we discussed the management of upper gastrointestinal bleeding. Today we will discuss with peritoneum and retroperitoneum. Our learning objective for this will be describe the structures and formation of the peritoneum with its developmental incorporation. We will demonstrate the distribution of peritoneum and will correlate some clinical condition to its function and structure. My first question is, what is the origin of peritoneum? Can anybody tell me what is its origin? You are right that it is Greek in origin, which means peri, around. Peritoneum, combination of two words, peri and toneum. Peri means around, tone means stretching. So peritoneum means stretched around or stretched over all around. What is peritoneum? Peritoneum is a serous membrane lining the abdominal cavity. It is the largest membrane in the body, which has a single layer of flat mesothelial cells lying on a layer of loose connective tissue. This submesothelial connective tissue contains macrophages, lymphocytes, adipocytes, fibroblasts. This peritoneum is comprised of two layers. One is parietal peritoneum and the second one is visceral peritoneum. This picture is showing you this division of peritoneum into parietal and visceral peritoneum. Parietal peritoneum, you know that it is outside the visceral peritoneum. There are some unique features of this peritoneal cavity. For example, in males, the peritoneal cavity is sealed, meaning that it is closed all around, while in females, it is open to the exterior through the osteo of the fallopian tubes, from which it gets connection to uterus, then through cervix, then through vagina. It is communicating to the external atmosphere. Then its innervation is through somatic nerves. So that's why it's respond to pain and stretch stimuli. While the visceral peritoneum is innervated by branches of visceral efferent nerves, whose are insensitive to pain and stretch. So there are some structures which are formed by the peritoneum. What are those? It is greater mentum, like this. Then hepatogastric ligament, which is a part of lesser mentum, like this. Then hepatoduodenal ligament, which is also a part of the lesser mentum, like this. then mesoappendix like this, and mesocolon like this. So these are the various structures which are formed by the peritoneum. We can divide peritoneum into different compartments to ease out our understanding. It has two parts. One is greater sacs and the other is lesser sac. This greater sac is again divided into two portions. One is supramesocolic portion and the other is inframesocolic portion. Supramesocolic, these are division based upon the transverse column. The area above this transverse column is called supramesocolic, while the area below it is called inframesocolic. Supramesocolic compartment is again divided into two portions. One is right, while the other one is left. On the right side, this space is again divided into two portions. One is subphrenic, second one is subhepatic, and the third one is lesser sac. While on the left side, it is divided into two. One is subphrenic, the other one is perihepatic area. While the inframesocolic portion is divided into right, left, and paracolic gutters. What are the relationship between viscera and peritoneum? Can anybody tell? Yeah. These are intraperitoneal visceras, then retroperitoneal visceras, and third varieties of extraperitoneal visceras. Regarding intraperitoneum relationship, you can imagine it like an inflated balloon, and some visceras are located inside this balloon, while other visceras invaginated this balloon from behind and stretching the peritoneum in front of it, and in this process carrying some portion of the peritoneum which forms their mesenteries. This picture is showing you this relationship and arrangement. And what are the functions of peritoneum? Can anybody tell? Yeah. Number one is to lubricate its viscera. The second function is absorption, and it is fluid and small particulate matters. Third function is to support various viscera. The fourth function is to allow movement between different viscera. The fifth function is to allow pain perception, which is function of the parietal peritoneum. That's how our patient can feel pain. It has also role in various inflammatory and immune responses, which involves the peritoneal cavity. Then the last function of the peritoneum is fibrinolytic activity. This picture shows you two major compartments of peritoneum. One is greater and the other one is lesser sac. We will describe these in next slides. What is epic-like phenomenon? So this is communication between these two major portions, that is between greater and lesser sacs. Can anybody tell me about its boundaries? Yes, we can describe as usual, like interiorly. Interior is free edge of the lesser omentum. And posteriorly is inferior vena cava and peritoneum covering this inferior vena cava. Superiorly is the caudate lobe of the liver, and inferiorly is the first portion of the duodenum. This picture is showing you the location of epiploic foramen and its boundary. And this yellow arrow is going inside the epiploic foramen. Having gone through this basic information regarding the peritoneum, we will discuss one by one with various peritoneal pathologies. What are those? Number one is internal hernias, and these hernias can be through epiploic foramen. This relationship is with peritoneum. So, before going into next slide, I will like to tell you about watershed regions. These are the areas of fluid stasis in the peritoneal cavity. And these are in the ileocolic region, in the root of sigmoid colon, and the pouch of Douglas. And the importance of these watershed regions are that when you are staging a patient for gastrointestinal malignancy, you will have to look for diseases in these areas of stasis. This picture is showing these major important watershed areas in the peritoneal cavity. What are the types of fluids which can be present in the peritoneal cavity? Mind you that a very small amount of fluid is naturally present in the peritoneal cavity. This is in a continuous motion. It is being secreted and absorbed to maintain lubrication, movement, and different functions of the peritoneal cavity. But when there will be excess of fluid, it will be pathological in origin. So tell me, what are the types of those fluids which can accumulate in the peritoneal cavity? Yes, the condition is called ascites. This is the city of that condition. There is a presence of fluid around the liver, so it is less radiopaque in shadow. Second variety is hemoperitoneum, meaning that presence of blood inside the peritoneal cavity. This is more dense in color, more radiopaque. Again, it can, depending upon its location, it can be present around the liver in case of liver injuries, or spleen around the splenic stroma around the spleen, and etc. And the third variety is pus or abscess. This is presence of pus inside the peritoneal cavity, and the difference of this abscess with other two varieties of fluid that there will be sectation inside this fluid. As you know, this computerized picture is showing various areas of radiopaque and mixture of radiopaque and radiolucent areas. Intraperitoneal abscesses may develop in combination with underlying inflammatory process. For example, acute appendicitis, acute cholecystitis, acute diverticulitis, various conditions of peritonitis, or after abdominal surgeries. Common causes include perforated appendix or perforated duodenal ulcers, and pelvic is the most common site to get abscess inside the peritoneal cavity. What are its clinical features? As these are common as with abscess in any other region of the body, like swinging fever with rigors and chills, can be associated with vomiting and pain at the site of involvement, And inside peritoneal cavity, it will be manifested as tenderness at abscess sites, which can be localized, or generalized abdominal tenderness if there will be a generalized peritonitis. So there are fourth variety of pathological condition which can involve the peritoneal cavity, that is presence of air inside the peritoneal cavity. This is called pneumoperitoneum. And can you tell me the causes of this pneumoperitoneum? You are very right. There can be numerous causes like bowel perforation associated with trauma, recent surgery. This is free air due to recent surgery, and it should resolve within 3 to 7 days. And if there is air inside the peritoneal cavity beyond 7 days, consider above two causes. Then it can be associated with the laparoscopy. As you know, laparoscopy needs insufflation of the peritoneal cavity with carbon dioxide. So residual amount of carbon dioxide can give you picture of air under diaphragm on plain X-ray of the abdomen. Then certain types of infection are also associated with the presence of air inside the peritoneal cavity. Certain air producing organism can have this picture also. So pneumoperitoneum secondary to any other cause is surgical emergency. You have to remember that it needs exploratory anatomy. Then there are tumors of the peritoneum, and we can divide these tumors into solid and cystic varieties, and we can divide these into common, less common, or rare varieties of tumors. Among common varieties are peritoneal metastasis, then metastatic lymphadenopathy, then non-Hodgkin lymphoma. It may be Hodgkin lymphoma also. Among less common retroperitoneal masses are carcinoid tumors, mesothelioma, sclerosing mesenteritis, mesenteric fibromatosis, primary peritoneal serous carcinoma, and among rare varieties are gastrointestinal stromal tumors of small bowel, then inflammatory pseudotumor. Soft tissue sarcoma can also involve the peritoneal surfaces, and the last variety is desmoplastic round cell tumor of the peritoneum. Among peritoneal tumors have certain unique features. Primary tumors are very rare, and its most common example is mesothelioma. And asbestos is its recognized cause, and it has a tendency to involve the pelvic peritoneum, and chemotherapy is the mainstay of the treatment. Then there is a condition called carcinoma peritonei. It is common terminal event of many abdominal visceral carcinomas, and deposits, meaning that intraperitoneal deposits, may appear as discrete nodules, which are the most common, or they can be present as plaques, or they can also present as adhesions. And the term commonly used for this condition is frozen pelvis. And that treatment should be focused on the underlying tumor. Common metastatic diseases which can involve the peritoneum are from ovary, stomach, pancreas, and colon. And the sites of implants are the falciform ligament, gastrophatic ligament, ileocolic region, posterior independent sites of the peritoneum, and broad ligaments in case of females. And there are some tips regarding these deposits that these are having rounded, ill-defined cake-like or cephaloid appearance macroscopically, and if the tumor is of mucinous region such as ovary or colon, it may show you soft tissue or fluid density. Mucinous or other treated tumors can produce small calcification throughout the peritoneum. What is pseudomyxoma peritonei? These are the encysted gelatinous mucus with epithelial cells which fill the abdomen, commonly seen in low-grade mucinous cis adenocarcinoma of the appendix and ovary. It is locally malignant and CT is usually diagnostic. Here is the CT pictures of this pseudomyxoma peritonei. All peritoneal cavity is mixed with gelatinous material. And treatment is usually with radical cytoreductive surgery along with adjuvant hyperthermic intraperitoneal chemotherapy. And recurrent tumors are again treated with debulking surgery associated with chemo or radiotherapy. We move on next topic, that is retroperitoneum. Our learning objective with this will be what is the anatomy of the retroperitoneum, what is the etiology of the retroperitoneal masses, what are the clinical features of the retroperitoneal mass, what are the investigations required to diagnose retroperitoneal mass, and what is the management of retroperitoneal mass. So retroperitoneum is a space between parietal peritoneum interiorly and fascia transversalis posteriorly. And the retroperitoneal organs are ascending colon, descending colon, duodenum, kidneys, suprarenals, pancreas, inferior vena cava, and abdominal aorta. How can we divide this? This retroperitoneal space is divided into three spaces by the perirenal fascia, which is called fascia of Gerota, and three spaces are interior pararenal space, which contains colon, pancreas, duodenum. Second space is perirenal space, which contains kidneys, adrenal glands, and the upper portion of the ureters. Then third space is posterior pararenal space, which contains fat, connective tissue, and the nerves. So its boundaries are interiorly posterior parietal peritoneum. Posterior boundary is armed with vertebral column, iliopsoas muscle, quadratus lumboral muscle, and tendinous part of the transverse abdominis. Superiorly is the diaphragm, and inferiorly is the levator ani and pelvic diaphragm. So what are the causes of retroperitoneal swellings? And again, in the form of hemorrhage, presence of bile, presence of urine, presence of enteric contents, collection of the infections, abscesses, inflammatory condition, and malignant. Solid neoplastic retroperitoneal neoplasms can be divided as benign and malignant, and depending upon its tissue of origin, these can be from adipose tissues, smooth muscle tissues, histiocytes, connective tissue, or lymphatic vessels. And there are benign and malignant varieties of these conditions. Among benign are lipoma, leiomyoma, benign fibrous histiocytoma, fibroma, lymphangioma. And their malignant varieties are liposarcoma, leiomyosarcoma, malignant fibrous histiocytoma, fibrosarcoma, and lymphangiosarcoma. Then there are other tissues like nerves, nerve fibers, and there are benign and malignant varieties of these like neurofibroma, neurofibrosarcoma, benign neurolemoma, and malignant neurolemoma. Then embryonic rests and notochords, and the condition arising from this are benign teratoma or malignant teratoma. But there are non-neoplastic retroperitoneal masses also there, like solid or cystic. Solids are retroperitoneal fibrosis, which is called Dermond's disease. Cystic are hematoma, urinoma, and pseudocysts. There are common constitutional symptoms which are associated with these retroperitoneal tumors. These can be in the form of fatigue, weakness, fever, loss of appetite, loss of weight, and indeterminate or vague back pain. What is a therapeutic implication of retroperitoneal zones? These are mostly to treat retroperitoneal injuries. There are three zones: central and peripheral zones. Zone 1 is a central zone, and it has a high risk of vascular injury because it contains inferior vena cava, terminal aorta, and usually surgery is required both for investigations and the definitive treatment. Zone 2 is second most common site of retroperitoneal hemorrhage. These are predominantly renal injuries, and penetrating selective exploration of angiographic embolization can be used to deal these injuries. For blunt injuries, observation and follow-up with imaging, and in hemodynamic stable with no active bleeding, you can adopt the policy of observation. Zone 3 are most common location of retroperitoneal hemorrhage associated with pelvic fracture. Here, usually no exploration is required in blunt pelvic trauma, and surgery is usually required for the penetrating trauma in this zone. What is the treatment of retroperitoneal mass? These can be considered as surgery for the stage 1 disease, for stage 2 pre-operative radiation, and surgery on the second choice with again post-op radiation. While for stage 3 disease, it is usually in the form of neoadjuvant chemoradiotherapy followed by debulking surgery, while stage 4 is not amenable to surgery. It requires only palliative chemotherapy or radiotherapy. So surgical treatment of retroperitoneal sarcoma is en-bloc resection with complete clearance of margin. It has 40 to 60% of complete surgical resection cure rate. Nephrectomy associated with this or colectomy can be a part of resection of intestine, can And if there are positive surgical margins, this is associated with high local recurrence rates, which is 50% in 5 years. Radical lymphadenectomy is generally not required in these cases. Indication for surgical treatment are localized resectable tumors, resectable tumor with isolated or pulmonary mets, and palliative debulking in symptomatic unresectable tumors. Approach can be open, laparoscopy, robotics, and while open approach is intraperitoneal or retroperitoneal, open intraperitoneal is the most favored one. Robotic approach has shown to decrease morbidity and mortality in retroperitoneal tumors, which are of less than 3 centimeter in size. But in Pakistan, this facility is not present up till now. Our open approach in CN can be midline, rooftop, which is called chevron in CN. Then there is thoracoabdominal approach or subcostal approach. There are two maneuvers to approach retroperitoneal tumor while you adopt policy of intraperitoneum. One is from the right side, which is called Catal maneuver. The second one is called Metox maneuver. Catal maneuver is mobilizing the right side of the colon and going behind that peritoneum, while Metox maneuver is mobilizing the left colon and going behind this and approaching the retroperitoneal area, depending upon the site of involvement of the retroperitoneal condition. In the end, this is an algorithm for management of retroperitoneal sarcomas. If these are less than 5 centimeter localized with no necrosis, usually resection is required. And if these are more than 5 centimeter with necrosis and calcification, initially biopsy with neoadjuvant chemoradiation is required, followed by surgical resection of this tumor. Thank you very much, my dear students. With this, we end up with our topic of peritoneum and retroperitoneal areas, hoping that you will learn and enjoy from this presentation. Thank you very much. Stay blessed. May Allah protect you. Allah.